And it's so great to see all of you here. I'm very excited about part 2 of this wonderful series on faith and medicine. My name is Jane Dutton, and I'm one of the members of the Adult Faith Formation Committee. And we also decided to distribute this listing of all the adult faith formation availabilities. There's 4 always after 10:45 every morning. Throughout the season, and we will have our one at the beginning of the season in January for the following season. But anyway, we get to the introduction of Dr. Christian Vercler. I am so pleased to have had the opportunity to meet you and to learn a little bit about your work. Just a brief introduction. He is a very special plastic surgeon. He focuses primarily on pediatric plastic surgery and craniofacial deformities in children and adults. In fact, I want to invite you to look at his minute-long video introduction at the U of M website. If you Google him, you will find it, where he talks about loving the opportunity to help children born with deformities straighten out their smile or improve their appearance in ways that improve their lives. It's really beautiful work. He serves as co-chief of the Clinical Ethics Service of the Center for Bioethics and Social Sciences in Medicine at the University of Michigan. He has a very fitting background for this focus. He is a Bachelor of Science in Biology and a Master of Arts in Theological Studies from Wheaton College. He attended medical school at the University of Illinois College of Medicine. He completed general surgery training at Emory University and plastic surgery at the Harvard Plastic Surgery Program. Finally, his interest in medical ethics compelled him to complete a fellowship in clinical ethics at the Emory University Center for Ethics, and he earned a Master's of Arts degree in bioethics from Trinity. He currently serves as the chair of the Pediatric Ethics Committee of the C.S. Mott Children's Hospital and is co-chair of the Adult Ethics Committee at Michigan Medicine. Additionally, he's chair of the Bioethics Committee at the Michigan State Medical Society. So how lucky we are to have Dr. Vercler. So please, the time is all yours. We really appreciate you being here.
Thank you. Thanks for that kind of introduction. I think, but probably what you guys know him for most is being the father of these little girls. That's my real claim to fame in life, and actually also tricking my wife into marrying me many, many years ago, so that we can have these kids. So, so you kind of ran over all these titles that I have at Michigan, but I feel like a lot of the things that I do has to do with kind of running the ethics program there, but also my day job as a surgeon, which is more visually interesting. So we're going to talk about some of the things that I do in the lives of kids. I like to start by sort of saying most people don't really understand what a plastic surgeon is. My kids thought this was really funny. But I should have worked harder on it. But so we're not surgeons who are made of plastic. We don't actually use plastic in the operations that we do, but plastikos from the Greek means to change, is malleable. So we sort of change the human body to try to reconstruct stuff. The quote that we love so much is from a guy named Gaspar Tagliacozzi in the 16th century. That's not Dr. Tagliacozzi, that's actually Joe Murray, who is the last living surgeon Nobel laureate, who won the Nobel Prize in Medicine in 1990 for his work in doing the first successful kidney transplant. He's a plastic surgeon. He started the plastic surgery program at the Brigham and Women's Hospital, and that's a picture of him, but then there's a picture of, there's me. I got to know Joe Murray because we did a Wounded Warrior project at the Brigham, which is where I spent some time. We did a series of face transplants at a place where we pioneered a lot of face transplantation, and it was really cool because Dr. Murray kind of did the first transplant. He was a plastic surgeon. His autobiography is called Surgery of the Soul, because he thought of himself as a craniofacial surgeon, even though he started the field of transplantation. He was the first editor of the Transplant Journal, even though he's as a plastic surgeon. What he really felt his life's work was changing children's faces, and so I can recommend his autobiography, Surgery of the Soul, really nice. But this quote is from Gaspar Tagliacozzi: "We restore, rebuild, and make whole those parts which nature hath given, but which fortune has taken away, not so much that it may delight the eye, but that it might buoy up the spirit and help the mind of the afflicted." And so I did general surgery before I did plastic surgery, and in my mind, it was a tough transition. The first few months of doing plastic surgery, I realized I was no longer doing life-saving operations. I did a lot of trauma surgery in Atlanta, where we were pulling people back from the brink of death, and that was pretty heroic, and you felt really cool about yourself being able to do that. And then really not doing life-saving operations, but changing the faces of children and realizing that what I'm doing is now more life-giving than bringing them back from the brink. When I studied theology, I had a professor who said, the one sort of theological concept that we have, for which we have real empiric evidence, is the presence of evil. And so there's so much hurt out there in the world. There's so much things that when you come face to face with, you go, how could this possibly, be the case? And so this is the kind of things that I take care of. So I take care of kids and adults, mostly pediatric, by 80% at the Children's Hospital. That's where my office is. And then I also do adults. And in kids, there's congenital problems, things that kids are born with, such as facial clefting and facial asymmetries, where one side of the face doesn't really grow. Crenosynostosis. I'm going to show some examples of some of these things, which is why we're not broadcasting it live on YouTube, out of respect for the children. The images that I'll show you, the parents have given permission for me to show them in educational environments, but once it's out on the internet, we use control of that. So thanks for being here to get to see it. I work with the neurosurgeons a lot on crenosynostosis or spina bifida, children born with large holes in their back with the spinal cord out. And then I work with the orthopedic surgeons in correcting scoliosis. So I get to work with a lot of other surgeons in a team approach. And then, of course, there's the acquired things that really break your heart. Pediatric burns, dog bites. I'm not a big fan. I am a dog owner, but I'm not a fan of dogs running around. And lawnmower injuries, if you can imagine. I won't show any photos of that. But and then I take care of adults who have had brain tumors or need reconstruction of their cranium, or who have bad cancer and need multiple operations for that. Do jaw surgeries and then gender affirmation surgeries to help keep as men look more congruent with their gender. So this is a patient. It's really he was born with a large tumor on the right side of his face that was resected in infancy, but it left the right side of his face paralyzed. And so, one of the operations that we do, it's kind of exciting, fun to do, is facial reanimation, where I take a nerve from their leg and transfer it up to and hook it into the working nerve on the other side, and then a year we let that nerve regenerate. Over a year, nerves take a long time to grow, and then we take a muscle from the inner part of your leg, and then hook up the artery and vein and the nerves, and then you wait, and then the nerve fires up and then can restore a child's smile. So it's very gratifying kind of operation that we do. The only other things that is my bread and butter is taking care of cleft lip and palate. So this beautiful little girl, was born with a cleft through her lip, through her gum line, all the way through the palate. So these kids have problems. You oftentimes late at night might see the ads for Smile Train and Operation Smile, because globally, a lot of these kids don't get taken care of in infancy. What we do is intervene early so that they can have a productive life, sort of interacting with their colleagues. And so the kids are not smiling in the photos that I show, because we have a protocol. We only take photos so we actually don't let them smile. They're happy, I promise. Here's just a bilateral, much more severe type of, so you can see, the little tongue, he's screaming, and that's a natal tooth, which is a little tooth that the kids are born with. Sometimes it just falls out. Anyway, that's what that is. My daughters really hate this one because the tooth looks so gross. But you can sort of see this hole all the way up into the roof of his mouth, and so kids can't communicate with an open palate, because all the air will rush out their nose, and so we close that up and then also reconstruct their lip. So this is again kind of our bread and butter. This young woman had a bilateral cleft lip that was repaired by another surgeon. She came to me that the middle part of her face is so flat and protruded that she actually can't breathe in that. So she has really bad obstructive sleep apnea and can't, just every time she falls asleep, stops breathing, has to wear a CPAP machine. That's something that I probably need. But in these kids, because they have a congenital sort of skeletal deformity, we have a way to correct it. Now, so it's actually kind of, very medieval, the type of stuff that we do, but I have to make incisions inside the mouth, make careful cuts in all the bones, and we hook up this thing called a halo. The reason I show this photo is that this is a happy girl, but has a certain appearance that she kind of was made fun of a lot, didn't feel real great about herself. As we're putting her through this very intense process, she starts feeling pretty, and came to clinic wearing makeup that matched the color of her halo, put on a nice dress, and was wearing lipstick and wearing earrings, and so and actually she's currently she graduated from the Aveda Institute here and is a cosmetologist, and so this idea that she went from sort of having and this is sort of her final operation about 5 years later, still with some asymmetries of her nose, but this is a type of we call craniosynostosis. Again, I'm just kind of zip through a couple of these kind of things that I take care of, and then we'll have more time to talk about stuff. But this is when the bones of the skull just don't grow; they're fused, and so based on which suture is fused, you can get these very bizarre head shapes. So this child, the suture right down the middle, called the sagittal suture, is fused, and so she has a very narrow forehead, is long as a football, and the top is very sort of flat. So we had to do this operation where I take, essentially the neurosurgeons take the bones off, and then they hand them over to me, and I reshape them and put them back. This is what it looks like immediately after. You can see that big long incision across his head, and then it hides under the hair, and it sort of from my standpoint, it looks good, which is great. But more importantly, there's room for the brain to grow, where before there wasn't, and kids can have a lot of significant problems if the brain is under too much pressure, with high intracranial pressures. This is a different type of craniosynostosis. This is the top-down view, where we call it trigonocephaly. The head's shaped like a triangle, and the forehead just can't grow, and that's a problem. The frontal lobes are important for interacting with things, and so these kids can have more issues with cognitive deficits, and so again, similarly, do have to do an operation where we kind of change everything up. But the thing that I really love, obviously, I'm a surgeon. I love doing technically difficult things and being successful at it. But we have a pretty robust social activity, so we have a multidisciplinary team that takes care of these kids across their lifespan, and that I'm lucky enough to kind of help to run. And so this is just yesterday. We went out to one of the fields here next to the baseball diamond, Ferry Field, and had a field day. Had a bunch of kids show up, and a bunch of medical students were having a good time with us as well, decorating pumpkins and doing sack races. But it's this idea that these kids can feel really isolated. Certainly the pediatricians kind of don't even really know what to do when they see these kids, because they're relatively uncommon. Cleft is between 1 and 750 live births, 1 to 2,000, depending on the population. Some of these other syndromic synostoses are, again, even more rare, so a pediatrician might never see them, maybe see 1 or 2 their whole career. Now, certainly the teachers and the other kids at school, there's no one else in school that has a situation like that. So we have these activities so parents can feel isolated having a child with facial difference. And so we try to do a lot of social activities where to get the kids together, so there's other kids that look like them, and the parents can also sort of talk to the other parents and say, boy, life's pretty tough, isn't it? All these extra doctor's appointments and things that we have to do. We have movie night and bowling and that. We do this fun thing too. This kind of I think it's a lot of fun. We have this glamour day once a year where we take over the Aveda Institute again downtown, and all the beauty school girls give all the kids and moms a makeover, and they do hair and makeup, and they have their glamour shots. And again, it's a lot. And then we have they do a runway show, and it's just so much fun to see these kids who sort of aren't really confident with their appearance, but to it's sort of silly a little bit in some ways to do a glamour day, but they just to see the smiles on their face, it's just so rewarding. It's a perennial favorite. Because I work with a lot of other surgeons, we do some really wild stuff. This was a case that a lot of these photos actually were in the media because this is the first conjoined twin separation done in the state of Michigan. So these two little girls were born sharing a liver and obviously sharing their chest and part of the lining of their heart. And so we had a big multidisciplinary team. Obviously, we had to put it in maize and blue. But we had, again, what's fun of what I get to do and interact with others is that the multidisciplinary nature of so much of these things and taking a lot of smart people to figure out how we're going to untangle these twins. And so we sort of did a lot of modeling, and you can sort of see on the bottom, if you just remove, they're missing the whole front part of their body. So that's where the plastic surgeons come in. The cardiac surgeons help divide the pericardium, the general surgeons divided their liver carefully, and then they turned it over to us, and we reconstructed their, and I say us because there's two kids, so Dr. Caston is my colleague. So again, a lot of planning that went into this. So we put these big tissue expanders in. It's kind of, I don't know if that's what the yellow things are. So we put these water balloons under the skin and slowly blow them up so that we have extra tissue to work with. There's a big team that did this, and so again, this was pretty cool. The day after we separated them, and then here they are, back at home, and there you can see that was sort of right after they were done up in the upper lower left. And then this was from just this early this summer. They came back and saw George Mialishka and Steve Caston, and now they're like I think 4 or 5 and real rascally and just living their great lives now, where they couldn't really even have done that together. So I kind of blitzed through to the shock and awe part of the talk, where you're like, what are these things that kids are going through, and then we'll talk a little bit more about where. How did I get here? So this is the farm I grew up on in central Illinois. I'm a Mennonite, so I grew up in a small farming community. That farm's been in the Vercler family for over 150 years, and all of my sort of forebears were farmers. My brother, that's from Google Maps, so that's actually what it looks like now. My brother lives there and runs the family farm. So how did I get there, and what's that thing about ethics? So I'm going to tell you a little bit, now that I got you hooked, we'll tell you a little bit more about how I got to this point, and then again, how my faith, I think, plays into it and got me to this point. So again, I'm just growing up on a farm, looking around, and one thing I say, the advantage of growing up in central Illinois is that I always felt like my horizons were limitless. There were no, like Chicago is like several hundred miles that way. It's flat all the way to it. Yeah. So my Opa and Oma, I'm German, and my grandpa and grandma, they had a very interesting story that really was influential to me. So they met in Paraguay. My grandmother grew up in the Ukraine. There was some German people living in Ukraine around between the 1800s and the early part of the 20th century. And so Catherine the Great invited these industrious Mennonite farmers to this part of the Ukraine to help make it the breadbasket of the world. And they were very successful. But they kind of stuck to themselves, these German Mennonites. And when the Bolsheviks took over, it wasn't so good for the landowners and people who were well off. And so my grandmother was sort of, she had started medical school, actually. I couldn't find a photo of her. She was like the only woman in her class back then. But the war broke out and everything. She wasn't able to finish medical school and ended up a refugee from because she had moved from the Ukraine to Germany because they really hated the Soviets. Lived in Germany and then escaped Germany because that wasn't a picnic either. Being a Mennonite, and so my grandfather, who grew up on that farm that I showed you, he happened to be in Paraguay. Working with refugees. He actually went down there to work at a leprosy colony, and then all these after the war, all of these immigrants came in from Germany, And so he was sort of reassigned to help take care of them. He met this young woman who was working as a nurse at the time. And then, again, he tricked her into marrying him and brought her back to that farm. And she was never able to finish medical school, and she just raised my dad and his sisters. But I would just always, I loved hearing their stories of traveling. I'm just going out and doing the chicken chores and having to take care of the sheep, and I just want to get off the farm, and hearing her stories of, and then we did this and we did that, back in the old country, and this idea that being a doctor was a good thing to try to do with your life. So that kind of set me on that path to try to get off the farm. And again, because luckily I had a younger brother who could take it over, because being the oldest and not taking over the family farm was sort of, it was never said out loud, but it's something that we thought about. So I went to this place, Wheaton College, which is where they really focused on, I don't know if you guys know about Wheaton, but it's really sort of a Christian college that's it's pretty conservative. I was one of the only Mennonites there. It was really a God and country kind of place, and I was, growing up a pacifist. I wasn't so sure about the ROTC guys marching up and down the football field. But I was pre-med there, and they made all the pre-meds, because it's a liberal arts college. I had to take my philosophy classes and my theology classes, all the Bible classes, and I had to take a class in bioethics. And part of Wheaton's mission is this lifelong integration of faith and learning. Preparing to be a doctor and studying about bioethics, where people talk about right and wrong with the decisions that the physicians make. And I thought, and all the texts they'd have us read were written by philosophers or theologians or legal experts at the time. And I thought, gosh, I should probably, it seemed, a couple of things. This idea of intellectual honesty, I thought, how does a philosopher know what it's like to hold the hand of the dying or be present to the sick when they're facing their darkest time? Wouldn't it be good to be trained as a physician and to be trained in these other disciplines so that I can contribute to this field? And so I kind of had that, as an undergrad, very idealistic. I'm going to get trained as a philosopher, a theologian. We'll figure that out. I don't know, I'm not sure, but I got to go to medical school. And then I was given the opportunity, and what that means, I didn't get into medical school. So I failed to get into med school. And I can't figure it out because my wife went to Harvard and she went to Columbia for med school, and we got the same MCAT scores. But I was really sort of distraught that I didn't get into medical school, and I was like, wow, God, what's this all about? I thought I was going to, live up to Oma's expectations of me and go be the doctor that she could never be. And then I realized this is an incredible opportunity for me to actually pursue this idea of really getting more theology training so that I can integrate my faith in my practice, in my life, and help to reflect on the things that we do. I mean, I give hour-long lectures to undergrads about what's the ethics of separated conjoined twins. And so study or reshaping a child's face to make it normal. What does that mean, normal? Or am I just reinforcing societal viewpoints of what's pretty and what's not? And there's a lot of things to unpack with all of the things that I do. And so I had the opportunity to study theology. So I got a theological studies degree. I can't marry or bury anyone, but I can think about Kant and Schleiermacher and Luther and all these theologians and stuff. So anyway, I finally did get into medical school. And I was at University of Illinois for there, and then got into Emory, which was where I had the good fortune of meeting my wife. And that's a different, different story, but I got her on the rebound, and so she was very emotional. But while I was there, I had the chair of, again, just talking about Providence. I was the chair of surgery at Emory, had gone to Wheaton College, and he took me aside right away when I started as an intern and said, I noticed that you studied theology at Wheaton and that you really are interested in ethics. Why don't I put you on the ethics committee? And so he actually ran the ethics committee because similarly he felt that his faith required of him to be at the table when making these hard decisions about right and wrong and life and death. And so that really he supported me to go get a master's degree in bioethics, and he supported me to do an ethics fellowship. And so and then I ended up at Harvard, where I got to meet all these amazing folks. I think we were just talking about the New York Times article about using placenta to resurface people's face, and they quoted one of my mentors there, Dennis Orgill. But that was a pretty terrific place, and I thought that I was feeling pretty good, getting to train at Harvard. We pioneered we did like 4 face transplants when I was a trainee there. To hang out with the Nobel laureate Joe Murray, and so it was pretty good. But then I finally made it to the top of Mount Everest when I got to Michigan. For those of you who are on faculty in Michigan, we know we break our arms patting ourselves on the back. This is Rock Patel, who's an orthopedic surgeon. I'm a risk-averse kind of guy. Anyway, so then when I got to Michigan, it felt that all of this training that I had been doing and just kind of was starting to things that fell into place. And I got to start a clinical ethics service at Michigan. So I have a team now of 8 faculty who have training in ethics. We have a 1.5 full-time people doing ethics consultation, where we go around and do rounds in the units and help people sort through their thorny ethical dilemmas. For 3 years, I got to teach a philosophy of medicine class to the undergrads, which was a real joy in helping to get these kids who are pre-med start to lay the foundation for what's their worldview going to be. How are they going to see, is this career that they're undergoing just about lining their pockets and getting famous, or is it about, working out God's grace in the world and kind of changing people's lives? And so and I still get to teach medical students. I still have a course on philosophy of medicine. It's just a 2-hour lecture now, but it's a lot of just, again, everything kind of came to place coming here at Michigan. So switching a little bit over to what we talk about, in the ethics work that I do, there's still a lot of brain death was something that was sort of sorted out a long time ago now, and the Universal Declaration of Death Act in 1981 sort of made it standard law that brain death equals death. There's still a lot of controversy around this, what does it mean to take care of someone whose brain doesn't work at all, but their body's still there, and what if families don't accept that? And we talked for a long time, and I'm going to wrap this up actually, and we will be able to talk for the rest of the time. But these are the kind of things these are issues that I've dipped my toe in, but I'm happy to talk about anything else. But trying to put together some national guidelines for what does it mean to do appearance-altering procedures in children. That it might be elective, or are they necessary, or what if the kid says they want different sort of things done? What does that mean? Or what if parents want you to do those things to their kid and the kid's okay with their appearance, but you think, well, maybe I could make them look a little bit better, but what's better mean, and is it better to me or to them? One of the things we deal with on a daily basis in the hospital is the fetal medical interventions at the end of life. Walking through an intensive care unit, or if you know any ICU nurses, sometimes you get a little bit cynical and nihilistic about what we're doing in some situations, and how do we help families get through those times? AI in clinical medicine is it's already here. What is there's so much to say about that. Maybe we can talk about that if anyone wants to during the discussion. And then, scarce resource allocation. These were our weekly meetings during COVID, trying to figure out what's the census, tracking everyone's, all of their labs and scores. There was an active dashboard of who were the people who were most likely to die and whether or not, if it push came to shove, would they get a ventilator or not if we ran out. And we were monitoring all that stuff, and thank goodness we never got that far, but like trying to figure that out, again, this is the old, you got 3 people in 2 lifeboats, who gets the 2 lifeboats and making those decisions.
Here.
Yeah.
You didn't have to make it here.
Right, the people did, that's
You
right.
had to make it.
Yep. And so, so again, just when I thought it was safe to not talk about scarce resource allocation, we don't have any more IV fluids. And so, so we're standing up our scarce resource allocation committee, and our first meeting is on Monday, even though we've been lots of meetings all last week. So this is, how to be faithful to when many decisions that we make are made for reasons of expediency or practicality or what makes the most money for the university and the hospital system. How do you be faithful to what we're singing about? We're called to justice. We're called to love our neighbor. And so how do I bring up those those things that I feel we all should be called to do, because God's the God of everything, in situations where there's so many other competing interests. I don't have an easy answer for that, but I try to be faithful. So with that, I'll wrap it up, and we've got plenty of time, hopefully, for questions.
I have a microphone. Please be brave. Who would like to ask a question?
So I'm sure the American culture gets into your discussions on many of these issues, for instance, feudal care,
Yeah.
end of life, and America being such an intensely individualistic nation, what the individual wants compared to what is better for society,
Yeah.
or even better for the person that's at the end of their life.
Yeah.
Is that part of what you all have grappled with? Have you discussed that, the influence of our culture compared to if you were in Sweden or if you were in Germany? What impact does that have?
Yeah, it's a huge impact. And the history of the field of bioethics in some ways is an outplaying of this idea of anti-paternalism. The bad old days when doctors made all the decisions were the bad old days, and we have to get away from that. And so starting in the 60s and 70s, and that's when bioethics as a field rose up, it was really voices outside of medicine calling for the rights of the individual patients, which shows somewhat needed corrective, but we've gone to the point now where it's sort of the only thing that my trainees think about is, well, the patients want it, so they deserve to get it. And you go, well, yes, but what if that treatment costs way more than the other treatments? Or what if that treatment actually only, and the family's asking for, what if it only adds to the patient's suffering? And they can't speak for themselves. And so I'm always trying to, and so the paper that I've been working on for 10 years with a friend of mine who's a sociologist called anti-paternalism, of saying, no one wants to say that we should go back to the bad old days, but what does love of neighbor look like when we play it out at the bedside, and you have to guide decision making. There's a strong, many physicians want to just do what the patients and families ask, because that's sort of American culture, because everyone has a right to get whatever they want, dang it. But so I'm constantly being the gadfly in these conversations, saying, well, what does it mean to really love this? What would it look like if we were trying to do the best thing for this patient? And what does really loving them look like, and how can we take what they're asking for and interpret that recontextualize what they're saying? Sometimes people are, I want you to do everything. You have got to do everything. What does that mean? Does it really mean that when the blood cloud is, their hemoglobin's 3 and they've got metastatic cancer, that you should do chest compressions and shock the patient? Does it really mean you have to do all these things? And so I always say, no, it doesn't, but in trying to push back, we try, so we in cases where we're called in, my clinical ethics team, those are the discussions that we have at the bedside with the family and the team, team meetings and that. We also have written some pretty good policies at the Michigan medicine level to empower clinicians and physicians to make decisions where they can sort of say, we're not going to do something that we think is going to end, if it's not going to work and it's going to only end increasing pain and suffering for the patient. But again, that's sort of paternalistic, and so I'm good friends with all the other ethicists in the state, and we meet about once a week to chat about how things are going, and they do not have institutions with policies like that. And so at Beaumont, for example, they just can't. They had a child who was totally brain dead, and they forced them to trach and peg the child, which seems to me like mutilating a corpse and totally against the dignity of that poor kid. But luckily, we had policies that prevented. We had a similar situation like that. It was in the news of a situation where families were requesting procedures be done on a child who was brain dead that we refused to do. And so that's kind of at the individual level and the policy level. I haven't done anything at the national level, but we're working on that actually with the AAP and the American Academy of Pediatrics and the Society for Critical Care Medicine. I'm on a group that's putting together what we call a brain death toolkit to help clinicians at the bedside talk to families about when their loved one is brain dead. How do you work through those thorny issues about what they, it's like the unthinkable has happened, and everyone has so much hope that people believe what we tell them, that we can achieve death, right? But medicine can't, and so how do we carry on those conversations and work through those thorny issues?
How is AI being used at all in clinical medicine, and what are sort of the applications and what sort of issues do you run into with it?
Of all the committees I'm on, I've kept myself off the ethics and AI committee. We'll go back to my first slide of those three little girls that I spent some time with every once in a while. I know that they're rolling out stuff for that, right? One of the ones that are being told is on the horizon is that there's going to be an algorithm that it's listening to the conversation and it's going to put together the note. So the big complaint is when you go to your primary care doctor's office, right? They turn their back to you and they start just charting while you talk. Okay. Now, luckily for me, I have residents that write on my notes. So they follow me around, and I just sit and focus on the child that I'm talking to. But yeah, if your whole life is charting on patients, so there's some things where it's listening and it's going to do that. Now, there's a couple of I've served on some panels with some surgeons where they have. I mean, AI's been pretty good at reading chest X-rays, for example, and shown that to be way better than maybe reading chest X-rays and mammograms, and not making the errors that humans make. I'm hopeful that maybe there'll be some AI that helps us with our algorithms in clinical decision making that can help us escape some of the cognitive mind traps that we get into. So I try not to be completely pessimistic on it, but a lot of the AI algorithms are also trained on data sets that are on all of us, right? White upper middle class individuals, and so if you train everything on that, what is it missing? And so again, those are the kind of the questions. But there's also some really interesting things about like intraoperatively when you're doing laparoscopic stuff. I don't do this kind of operations anymore. You have a view from a camera, let's say of the gallbladder, and so I know that there's some things where they're talking about the AI can help you identify the critical window of safety to help you prevent from injuring the common bile duct when you're taking out someone's gallbladder. And But then the question is, well, if the AI algorithm told me that that was okay, and I did it, but it wasn't okay, who's to blame? And surgeons, we beat up on each other. We take a lot of responsibility for our outcomes, which I think is a good thing. But if you've got the bot helping you make decisions, what does that mean for responsibility? Yeah, that's a long-winded question.
Well, last question,
Yeah.
I think. You mentioned you're teaching medical students philosophy of medicine, and I'm wondering, what is their reception to that? Do you have crowded? I mean, I would hope that actually that it would be a requirement, or that ethics is a requirement, and so what kind of a response do you get?
So the kids that I like currently, it's just probably a handful of students, 10 students, who sign up for a religion and medicine course. And as part of that little course, they get 2 hours with me where we talk about what's it look like to develop your own philosophy of medicine. What sources do you draw on, to build that. And so again, but yeah, no, it was. It's in terms of ethics that we used to give. I'm glad I'm not in charge of the med school curriculum. It's very challenging, but a lot of that stuff gets cut, has been cut. So we used to do intense, several hour, a couple times a year. We would do these case discussions where we'd go over 3 or 4 cases and lead the students through it, and it was that's all gone away. They have a different. Students can minor in ethics now, so in typical Michigan style, we call it a path of excellence. So they can go down the ethics path of excellence if they'd like to. And so we have a reasonable, about 15 kids a year will sign up for the ethics path of excellence. And so then they get a whole lot more extracurricular lectures and sessions with my ethics faculty.
I'm mindful that Dr. Vercler has to leave because their kids at 11:30 are going to be let loose, right?
Yeah, they're pretty self-sufficient though, so we can do maybe one more question.
Okay, one more question? That would be great.
Dr. Vercler, thank you. I'm Beth. And I'm curious, is it ethical? I imagine when you have families come in who have a horrific issue, a lawnmower, anything else, a shot, a gunshot. Do you ever get around to conversations when you're trying to deal with these heightened, emotionally charged people to their religion? Can you say, have you seen the chaplain? Have you seen, in your position you can't obviously just promote Christianity.
Right.
Do you get a chance to do that? Is that ethical?
So I don't. It's primarily it's because it's not expedient to do so. Honestly, I'm a very busy surgeon with no time, and so what we did though is so we did a project. So I've got a lot of trainees. They need to write papers and try to write grants, and so I have a trainee who. What we did was we surveyed kids who come to my clinic. We surveyed the parents who have a child who has a new craniofacial diagnosis. So they have a diagnosis of a child with, and we do prenatal consults as well. But to try to, there's some validated instruments that can measure spiritual distress. So chaplains use these. They're the same things that a chaplain would go through to measure spiritual distress. And so we administer a spiritual distress survey to the families of kids who are new patients into my clinic. And then we connect them with the spiritual care department at Michigan. So I again, but it's only laziness that keeps me from doing it, because I wish that I could have the time. I mean, how do I try to? I'm always about an hour to 2 hours behind in my clinic, and it's because I think that it's really important to just be present with patients and their families and listen to them. And so that's the practice that I do to try to at least let them, if they want to say something about the spiritual distress, that I'm at least listening to them, that they don't feel like they're just being shuffled through, that I'm respecting their, the image of God that's in them. And then no one complains about being late because I just spend as much time. I'm always like, sorry I'm late, and then I give them all the time that they need.
That's a beautiful thing.
Practice, though.
That's a beautiful thing. Well, I have three things I want to mention. First, I want to, while everyone's here, just say thank you on behalf of the Adult Faith Foundation, but also thank you on behalf of the congregation for sharing your gifts with us. And I have, as Bill Gruber knows, a little token from the
thank you.
Adult Faith Formation as a thank you. Very inspiring. And this is part 2 of a series that Dr. Bill Gruber did last week, which was recorded. It's on our YouTube channel. It was also really inspiring, so I strongly encourage you. Unfortunately, this one is being recorded, and maybe there could be a special request, but we're not putting it on, as he said, just to protect the children whose pictures are up there. But I also, in my role, have to do a shout out for what we have coming up. So we have, it is voting season, if you didn't notice. So we have part 2 of Politics and Faith, How Should Christians Engage in American Politics? That is next week on Sunday, and Margie Rounds and Diane Hockett are going to host is it Todd Coffey? Is that the right name? Yeah, Reverend, Todd Coffey. That should be wonderful. And then the next week, on the 29th, we have Barbara McQuaid, who, if you know, is in the press a lot, has a wonderful new book on disinformation, and that session will be held in the sanctuary. So please come back. But here, now we need a robust round of applause.